I know that the talk was like key infectious diseases. I didn't really know what I was going to talk about when I kind of had to throw in an idea. And there's just so many different infectious agents out there. So pretty much the first half we're going to talk about FIP. And I know it sounds like you guys probably know a lot about FIP, but there's definitely some new things that, these are refreshers that when I had a recent case that I had to review, I'm like, oh yes, this and that. And there's some new stuff out there too. So hopefully this doesn't bore you, and feel free to have any kind of questions, interject any times. I'd like to keep it kind of pretty informal, And then our second half, we are going to talk about enteropathogens. I don't know, are you guys all familiar with Journal of American Veterinary Internal Medicine, where they will, every year, they always have a consensus report. And I highly recommend people reading that, because it's a really good overview of a lot of key topics, a lot of controversial topics, or just things that really want to throw out there. And in 2011, it was all about enteropathogenic strains of bacteria, which I think there's a lot of confusion, and also just how we go about diagnosing it, to the way we treat it. And I just thought it was a really good consensus report. Just in general, I think that every year it's a pretty interesting article. So quick review of that. So FIP is a coronavirus. Okay, it's a very large envelope virus. Remember, with RNA genome. And there are two biotypes. And the biotypes, as everyone's familiar with, is the enteric coronavirus, which many cats have, and then the infectious FIP, known as FIP virus. And the thought is, if it's a mutation from the coronavirus, that's the enteric form, to the FIP. And there was one question, an article that was noted in 2007 where they had a cat with FIP, and it was interesting because theoretically the coronavirus should be only in the intestines. It's nowhere else, okay? And this cat had true FIP diagnosis with histologic diagnosis, and they actually found it in the liver. So we know that the coronavirus shouldn't be in the liver, the enteric form. And they actually sequenced it and really had exact same sequence. So it's kind of weird. If you mutate, you should have something that the nucleotides should be a little bit off, and it was exactly the same sequence. So it does kind of just throw it out there. Maybe is it a true mutation or not? Who knows? But at least currently, that's what most people will talk about. It is a mutation from an enteric coronavirus to FIP, which is the more fatal infectious disease process. So majority of cats, as in 90% plus, actually remain healthy. There was a long time ago, I think in the 70s or so, a lot of people were actually euthanizing animals when the coronavirus came out, and obviously we learned that that's not necessary, because the majority of them are healthy cats. And the whole point is that the genome is pretty large, and that's why they probably tend to mutate more. And that's where the thought that a lot of mutations do occur, but thank goodness most of them are not harmful. But occasionally you will get to the point where it turns into a true FIP, and that's where it will actually be quite harmful to the host. The exact mutation is still unknown. So no one's supposed to be reading this. No one can really see what it says. But the main thing, I just wanted to have it in your slides, so if you want to reference where the journal versus trying to write it down, it's a quick key abstract. So the really important thing to remember is that the mutant FIP virus arises within the individual cat, and it's their own coronavirus that actually mutates. So it's not a FIP to FIP cat, okay? And it really is so what happens is that the coronavirus, enteric coronavirus, infects the mature intestinal epithelium, and then it sheds in the feces, and that's where it can spread to other cats, at least the enteric coronavirus. But the FIP virus is actually one that infects monocytes and macrophages. So it really is no longer in the intestinal tract, and it rarely sheds in the feces. So because of that, the transmission of FIP from cat to cat is the really exception and not the rule. So when you have a client that comes in with FIP, a bunch of cats and such, obviously, it's ideal to still I like to isolate that kind of possible, but theoretically, the likelihood of spreading is still not very high. Is it impossible? There have been a few cases where FIP did seem to show up in one household, 2 cats. Is it the 2 different mutations, or for whatever reason, for the same reason when we saw that the coronavirus in the intestines, in the liver were all the same? I don't know, can they go to the intestines? There are some of them that actually can be the FIP virus, actually also be in the intestines. I don't know. So the key point again is that the cats ill with FIP are unlikely to risk other cats, especially adults, so you may not need to isolate. So FIP is a really infectious virus. The coronavirus, enteric coronavirus, is a very, very infectious, highly infectious virus that's fecal-oral. And we still try to minimize that spread if possible, but the problem is very difficult in a multi-cat household. And usually, if you do have a multi-cat household, about 80 to 90% of them will be infected. Okay? And general cat population is really 30 to 40%. But if you look at feral population, it's actually quite low. Again, they're not really in tight communities and sharing a lot of things. So this is my house too, on the right. So the frustrating thing everyone knows, in vivo can be quite difficult. And in a European Veterinary Internal Medicine abstract in 2011, there was actually a pretty good abstract that kind of had a retrospective look at effusions from June 2009 to February 2011, where they had 32 thoracic effusions, abdominal effusion was 37, pericardial was 1, and 17 of these guys had FIP based on histopath or a very high statistical likelihood of having FIP, and there were 50 without. And they looked at all these cats, and they tried to look at the PCR and the infusion, and they actually found that 100% of them were detected as FIP, truly were FIP in the PCR effusion, and 98% specificity. And when they looked at the IFA coronavirus antigen in the macrophages in the fusion, it was 71% sensitive and 96% specificity. PCR in the EDTA blood was 92% sensitive and 100% specificity. So pretty much PCR looked pretty good. In the feces, it was a little bit less at 0.82 sensitivity and 0.76 specificity. This study in particular was interesting because they looked at EDTA blood, because a lot of people are actually using serum for the PCR, and so they thought maybe the EDTA blood is maybe a better way to go about looking at it with the PCR. And then when you're trying to diagnose it, a lot of people will use albumin and globulin ratios, and in the same study, if they did a cutoff of 0.6 as a threshold, the effusion was 0.82% sensitivity and 0.8 specificity, and serum was a little bit better at 0.88 and 0.66, but less specific. Okay. And actually, any form of detectable antibody titers to the coronavirus, it was almost all the FIP cats had some type of coronavirus and titer. But the specificity was not very good. As we kind of know, a lot of cats will have a positive titer. Now, remember, this is just this study, so you'll see many things are out there, but at least I thought it was just kind of interesting because I had a lot of cases. So if you actually look at albumin and globulin ratio in the effusion, if it's greater than 0.81, this is really highly predictive for ruling out FIP. So it's very, very unlikely. Okay? And if you look at plasma proteins, non-effusive form shows about 75% cats have plasma proteins greater than 7.8. So I think sometimes it's also good to realize that the test is done not to rule in, but it's sometimes even better to rule out. Just kind of like the cortisol in Cushing's when you're looking at the urine. It's good not to rule in, but to rule out. And then this is just a retina with a vessel cuffing. A lot of times the globulins are so high, they'll kind of spread out along the vessels. So the Revolta test for FIP, has anyone done that Revolta test by any chance or do it at the clinic? Yeah. Was yours successful? Can you see it? Or?
I actually did about 3 of them, and one of them was positive, you could tell.
Yeah. So it's a really neat test. I mean, theoretically, you just grab 8 to 10 mils of water. You know, it could be tap water, distilled water, and you could just take regular basic vinegar. You know, I know there's some people that use like a 98% acetic acid. I think it's just regular good old vinegar, white vinegar. You put 2 to 3 drops, usually in a test tube. You know, you could just take one of the serum, or there's no, what are they called, serum separators. It's just a plain old tube. Fill that up, and then you added 2 to 3 drops of vinegar. You could shake it, whatever it is, but at least it makes some type of mixture. And then you put your FIP fluid drop on the top, and it'll start to sink down, and it has this kind of weird, you know, they always describe it as like a jellyfish kind of, you know, and then starts to kind of float downward, and that's usually a positive. If it just kind of looks like smoke and it kind of dissolves and disappears, and that's usually a negative. So this is really popular in the past, but quite honestly, I think now there's so many other better tests out there, but I think it's kind of quick and dirty and easy. But they realize that the sensitivity is really not great. It used to be in the past, they talk about, sensitivity of 91% in some studies, and then 0.53 sensitivity is kind of more recent. And a lot of people will use a positive predictive value of 86%, and negative predictive value is 97%. But you will get false positive with bacterial peritonitis and lymphosarcoma. So now in 2011, they kind of changed the positive predictive value after more studies have been done. It's around 55, 56%. So it's not perfect, but it does improve. If you exclude lymphoma or bacterial peritonitis, then it does jump up, And then if you have a cat less than 2 years of age and has abdominal effusion, then it really goes up even higher, in the predictive value. And then if it's less than 1 year, it goes to 90%, almost 91%, and a negative predictive value of 94.3. So I think it's still a useful thing, but just be careful, because sometimes you will have these effusive lymphoma cats that are young, But most of my young lymphoma cats, they tend to be mediastinal for whatever reason. When I'm treating one right now that's 1 year of age, and it's that seems to be more common than the abdominal effusive form of lymphoma, which I tend to see more in older cats. But okay, so coronavirus antibody titers. So IFA and the ELISA FIP7B specific, they're all really non-specific. So it's really important to remember that. And cats with FIP tend to have higher titers than cats without. So even though the titers, a lot of cats have titers, but in general, I do find that they tend to have a higher titer. And so I still feel like it could be useful, but just be careful not to overinterpret. And cats with FIP can have negative antibody titers too. So there's just no perfect test out there. So just because if you're highly suspicious of FIP but your coronavirus is negative, don't completely rule it out. And that's where so many other things need to be looked at. And I still tend to use FIP titers a lot when I have a cat owner is concerned because we just diagnosed their cat with FIP. Now they're wondering if, how's the other cats. Sometimes if I worry, again, that very, very rare transmission, because it really shouldn't be transmitting through the feces. If they want to get a baseline of their other cats, and then if they suddenly get sick, you could see a rise in titer. Maybe it could be a little bit helpful. But I know there's definitely holes in that too. But sometimes it just gives you a peace of mind where you start out with. So the FIP RT-PCR. So it's a DNA, and it detects messenger RNA from the MG in the peripheral blood. And then people were really excited about this test because they thought that it could really distinguish between clinical FIP and healthy cats, because theoretically you should only be making mRNA of this virus in the blood, which, again, enteric coronavirus shouldn't be in there, in the monocytes, and it shouldn't be actively dividing. And this is telling you it's looking at mRNA, so there's true active division or amplification of the virus. And so the theory, again, is mRNA outside of the intestinal tract is indicative of active replication. In contrast, non-FIP coronavirus strains replicate in the intestinal tract and not in the blood. And, now with this type of assay, it's not, they really quantify how much the virus is in there too. And you'll hear, a lot of people doing a real-time PCR, or there's so many different names for it, but I know the IDEX, when you run it, they call it a real-time PCR. It just not only amplifies the actual DNA, but eventually the old method was use agarose gel, and you could just kind of put the DNA fragments in there, and then you'll look at how it kind of moves through a current, electrical current, and then you look at which ones are positive or negative. And if it is positive, like this is where the target, and this cat was negative, and this one's positive, then that's, you just say positive or negative. But the problem with this type of old style of PCR just tells you positive or negative. Real time is actually amplifying the DNA, not waiting for the end product, and you cut it up into pieces and you look for the segment that is part of the virus. This one is actually amplifying in real time, and that's why they call it real-time PCR. And then you could tell like how much amplification there is. So it actually quantifies how much of that fragment is in there. So now it's really nice to know more about the quantity, not just negative or positive. So everyone was really excited about that test. And then there's a paper that came out in 2007 where really they had only one cat with FIP, they knew for sure, and they took a bunch of other cats that didn't have FIP, and they found that they were able to find some of them positive without clinical disease, okay? And so they felt like there's a high rate of positivity among healthy cats. So there's really poor specificity. So pretty much they're thinking, you can find the coronavirus in the blood samples from healthy cats. And so now the question is that really going to help us out differentiate between the two? So really the gold standard is ultimately going to get biopsy histopath. And it has a very unique type of inflammatory pyogranulomatous inflammation. And ultimately in surgery you can find a lot of other hallmarks such as fibrin, enlarged lymph nodes, thickened bowel sometimes, and granulomas on the different organ structures. So the presentation of these guys, typically they're young, but 3 months to 2 years on average, but you realize that sometimes you can have older cats. We could diagnose FIP in 11, 12, 13-year-old, but the majority are young. And multi-cat households, often shelter and catteries. And there is some kind of link in certain breeds are more affected, but it varies from country to country, and I suspect it's also how clean the environment is and all that too. The genetic predisposition maybe is part of the factor of why some animals do get FIP, and there definitely is a link between concurrent illnesses, especially FELV infections. And stressors that are in the new home, elective surgery, inter-cat conflict, whichever ones that kind of weakens your immune system. So there are two clinical forms, the wet and dry. I'm sure a lot of you guys are all familiar with, but really they're not mutually exclusive. People used to think you only could be wet or you only could be dry, but really now some people will call it mixed, and maybe there's a more of a transition from one to the other. And we're seeing like maybe more non-effusive forms and increasing, but I don't know if it's really truly increasing versus maybe we know so much about FIP, it's been kind of drained into us in vet school, and now you're just going to be, just because you don't have effusion, it has to be on your differential list. You have the icteric cat, those definitely FIP has to be a differential. And there's lethargy, anorexia, weight loss, and sometimes often out of proportion to the decreased appetite, and cyclical fevers, and that's not really responsive to antibiotics, and poor growth rates. And it really can last from a few days to months. And the wet form tends to be a lot more rapid, but sometimes you can have a poor doer for like 3-4 months until they really truly become full bloom of very easy to diagnose. So it should be up there if you have the cat that is a little bit off, and they don't have to have the super high globulins yet. So vasculitis is a key thing with a wet form, and it could be in either cavities and sometimes even in the joints. And really in young cats, if you have a young cat that has ascites, it's probably more common than heart failure or neoplasia or renal or liver disease. I know a lot of people, when you have a cat with abdominal effusion, you think of heart failure, but actually with heart failure in cats, most of the time it's going to be pleural effusion or congestion in the lungs before it truly gets to the abdominal cavity. And non-painful, non-septic exudate. So again, many of these guys that are non-painful, they can have FIP, and then some of the parameters that you look at. But it's all over the place, quite honestly, with this high protein, albumin, globulin ratios. I mean, that's just a guideline, but I think there's just a lot of overlap between other effusive diseases. But it does have pretty low to moderate cellularity. So nothing too exciting. You see the effusions, fluid, potbelly appearance of the kitty. Sometimes you'll get these little fibrin clots and such in the eyes. And so the non-effusive form, I think this is the one that actually gets probably referred the most, because most people don't even send the effusive form, because you guys are able to get a clearer picture of what's going on. But the one that are just granulomatous, and you're not going to find it just on physical exam. And that's where it's going to be really important to get an abdominal ultrasound if you have enlarged lymph nodes. And we always, will aspirate, and sometimes you have liver elevations, we aspirate those. Occasionally it'll be in the kidneys. It could really be any organ in the abdominal cavities. And the thing that a lot of people forget to always look at the eyes. The eyes are you don't have to be blind yet, and a lot of times it could just be as subtle as just a few granulomas in the back. But clinically, if you just look at the cat's not going to be blind. It doesn't even have to have uveitis or anything like that. So, all animals that we do a physical, we should try to do a fundic exam. And ultimately, they'll oftentimes come on neuro because they're having ataxia seizures, nystagmus, tremors. It could be very, very vague signs, but they're just a little bit off neurologically dull. And it could even be multifocal. It could be almost anywhere in the CNS. And what's interesting is that they had a study where they looked at young cats and they CT these guys, and a lot of them had hydrocephalus. I suspect it's kind of blocking the drainage of the CSF, because this protein is super high oftentimes, and that's where when you're tapping these FIP cats, a lot of times sometimes you don't even get fluid because it's just so thick. It doesn't really come out easily. Because especially like the little young cats, they're not that difficult to tap. And sometimes if you get a negative tap, that, our neurologists used to tell us that makes even higher suspicion sometimes, So abdominal involvement, you have the granulomas in the mesenteric lymph nodes. A lot of times they can be quite large. And the kidneys and liver are probably the top 3 areas. And you'll see adhesions in omentum and mesentery. And on ultrasound, they just look really thick. They really almost look like carcinomatosis, but they don't have the fluid, And what's interesting is that a lot of these guys won't have fluid in this granulomatous state, even though you have these gigantic lymph nodes, thick mesentery and such. I suspect over time they will start to effuse just because they're having poor drainage system in their mesentery and omentum. And sometimes they'll have GI signs, mild colitis or mucus or blood. So again, if you focus on the coronavirus itself, so most of the time you're trying to decrease if you have a single cat and you're bringing a new cat in, obviously if you have a negative enteric coronavirus, you'd like to try to keep it that way, because if you don't have the coronavirus, enteric coronavirus, you're not going to get FIP. There's nothing to mutate. So people are still trying to keep everything clean, but however, there's something that you can't control, and some people feel like maybe it's possibly in utero. And maybe that's when these kittens start to have diseases, when like 2 kittens in a litter. Maybe they didn't get it from each other, but maybe they got it in utero. And in the virus excretion and the coronavirus itself, it's pretty hardy. It could go through the oral respiratory excretions, feces, and possibly urine. But most of the time, it's really the feces is the big one. And really has to be close, sustained contact between the cats. So really that's where the mother, taking care of the kittens, and unstable outside the host, all right? But it can persist as long as 2 weeks. And good old household detergents will kill the virus. So, or you could just go ahead and do 1 part bleach and 32 part water. So it's pretty dilute bleach. So how do you again get the FIP? You have to have exposure to the coronavirus. So that's where we try to target. If you want to try to prevent FIP, you're going to try to really just prevent coronavirus spreading. And then it has to mutate, and at least that's the current theory. And mutation is in the individual cat. It has nothing to do with really jumping from virus to another cat spread. And there probably is a genetic predisposition. So certain treatments, and there's a lot of stuff out there. You're going to have owners really desperately trying to find things and asking, what are some of these things? How should I try it? But there really has not been really effective treatments out there. And there's been several papers on each one of these things, and none of them have been effective. We were really excited the feline interferon omega. I know there was a lot of people got excited initially, but there was really no good controlled study for that particular interferon. It's something in France, and so anecdotally, I know that a lot of people will use because you can't get the feline interferon very easily in this country. So we use human interferon alpha, and people do this. I doubt it really truly works, but you can try it. And pentoxyphylline, everything about the vasculitis, should it really work? There has been another study that's been out that showed that there's no difference. But at least these are some of the doses. Prednisolone seems to be the mainstay, keeping inflammation, helping with the appetite. And cyclophosphamide or chlorambusol, again, sometimes trying to immune suppress, really. And I just feel that, I don't know, we're really prolonging survivability or quality of life, but if you have that desperate owner, these are some things you could try. But remember, if you're using chemo drugs, you really have to do CBCs and such. The last thing I want to do is make them sick from the chemo because they're immune compromised. So, and this is a paper in 2007 that looked at feline interferon omega, and this was probably the only controlled study, and unfortunately there was no statistical difference between survival time between that and placebo. So investigational treatment. So this one is very interesting. It's polyprenyl immunostimulant, and it's actually in Tennessee, and it's supposed to enhance cell-mediated immunity, okay, through toll-like receptors. And this seems very promising. I don't know what will happen when the final study comes out, because there was an active recruiting of cases to test this drug, and I think that study is closed now. But it really was a plant-derived material that was supposed to be a pretty safe compound. And originally they challenged this with herpes virus induced respiratory infections, and they found that these cats with herpes virus seemed to get better a little bit sooner and just decrease the severity. So then they actually started to do this on other things, and I know talking to Dr. Flood that was just at UT, she was saying that they're trying, Dr. Legendary, they use this stuff on everything, from cancer to, random stuff, because maybe to help any kind of cell-mediated immunity. And they're finding interesting responses where cats are living longer than we kind of expect, sometimes 2 years, 3 years with FIP, dry form. And so it's not, they're trying to license it, and so that's what it's going through right now. And so in order to get this solution, it's just going to come in little vials, the 10 ml vials, you have to go through Dr. Legendary. So you contact him, super nice guy, and you have to kind of go over your case. And it really has to be kind of pretty confirmed diagnosis of FIP. It can't just be a simple high titer, and it only can be dry form. The wet form does not seem to be effective, And in each vial, I have 2 cats on this, and so far they're doing pretty well. One of them is truly just a litter mate of this cat that has active FIP, has granulomas in the eye, came in with fever, wasn't eating. We actually did abdominal ultrasound, had enlarged lymph nodes, FNA'd, had pyogranulomatosis inflammation. Titers were 1 to 6,400 for FIP, and the 7B was also high, like 1 to 800 or something like that. Globulins were high. I mean, just everything kind of fit the classic dry form of FIP. But really, Dr. Legendary really wants a pretty good, thorough workup before you say, hey, I just need this stuff to try. And then once he says, okay, you can get it, then Dr. Sass is a person that kind of mails it to you. And, you know, it's up to you if you want it's probably better control, I should say, for them to mail it to your clinic and then you charge a client, you know, versus trying to just have it in the hands of the client, quite honestly, because you want to make sure there's follow-up and everything else. Each vial, it's about $9 to $13, and that vial for the little cats I have, the 2 cats, I think they're maybe like 7 pounds, 8 pounds, 7 pounds-ish. And each vial would give 2 doses, and it's every other day, about 5 mLs. So each vial will give 2 doses. It comes out to be about $18 a week. So it's not cheap when you think about long term, because if these guys are living 2 to 3 years, you have to have an owner that's pretty committed to do that, and it could add costs, you know, over time, because you should still kind of check them out, do physicals, make sure the weight is still, you know, the same, and you have to increase the dose. So my cats that I'm actually having to recheck tomorrow, I think they've really, it's really one of them, because the other one is just kind of there, and she really is very concerned, so she wanted the PI for that other cat too. And I want to say it's been 2.5, 3 months, and this cat was pretty sick when I first started, and the cat now looks kind of normal, but blind, you know, developed uveitis. It went through all the whole process of FIP, but seems pretty happy eating. Still has mild fever sometimes, but doesn't seem to affect the cat. So we're hoping that this may increase survival time, and I think it's something more promising than some of the other stuff that's been in the literature. And we really prefer it not to be on steroids if you're going to use this, if you can. But if it's a last resort, so be it. The reason why is that if you use steroids, the whole point of steroids is to suppress the immune system. And with this polyprenyl immunostimulant, you want to stimulate TH1, you know, and that's where it could be tricky to not suppress the other, because you want cell-mediated immunity. And so this is a paper that Dr. Legendary had, which is pretty much a case study of 3 cats, and 2 of the 3 are still living right now, and they've really done well 2 years after diagnosis, and then the 3rd cat survived 14 months, but that cat only had a 4.5-month treatment of this polyprenyl. So it just sounds pretty amazing in the sense that most cats, from experience in the past with FIP dry form, they don't really live more than a year, you know, maybe occasionally close to a year at best. So again, it's one of those things where you want to enhance the TH1 cell-mediated immunity versus the TH2, which is humoral immunity. And that's where the polyprenyl is supposed to help there. So if you use steroids, you knock out both, and then therefore it's really hard to use 2 drugs at once, you know, where one is pretty expensive and you're not really getting the true benefit. But I think when you're really desperate, the cats really go downhill, you need some type of appetite stimulant. Steroids is probably what you're going to reach for. And the FIP vaccine is really not generally recommended at this point. There's really no independent study that says it's effective. And really, again, cell-mediated immunity is the only beneficial protective response. And with antibodies, it actually enhances virus uptake in phagocytic cells. So the antigen-presenting cells will kind of be cued in to eat anything that has the antibody stuck to a cell. All right, then we're going to switch gears to more poop, but it's going to be dealing with enteropathogenic bacteria, okay? And this is pretty much a summary of the consensus report of 2011. So pretty much why did this kind of get put out there? And really there's a lot of indiscriminate testing and misinterpretation of results when it comes to feces and bacteria. And there's really poor practice guidelines to help us to tell you, all right, how do we go about doing this? And there's also very bad validated immunoassays for dogs. We really don't have them. We a lot of times will extrapolate from human medicine, but it's not the same exactly. And oftentimes we are trusting just way too much on molecular-based testing. That's pretty much how how DNA. It's not that easy, and that's why O.J. Simpson, for example, got off. But there's still some things. So I think that ultimately, with all this information out there, the college decided to kind of go over some of the key diseases that may be helpful in trying to tell you the diagnosis, how to test for it, and such. And it's interesting because a lot of times I do see, when I get cases referred, I do see sometimes people are just culturing feces. And it's tricky because you're going to get growth of bacteria. And it's really hard to say which ones are the ones that are affecting the animal, and how do they even culture it and go about collecting the sample. And really, you need about at least 2 to 3 grams of fresh feces. IDEX, in their recommendations for when you kind of look into their catalog, they want actually 5 grams. But it has to be a clean, sealed, leak-proof cup or sterile container. And it really needs to be transported as soon as possible to maximize the survival of both the Salmonella and Campylobacter in particular. And really, it should be processed within 2 hours of collection, and that's really, really difficult. And if it's not possible, which is probably the majority of the case, you really should be putting it in some type of medium, transport medium, okay? And in rectal swabs are also not really ideal because it's really a very small population you're getting. And if it is used, you really should, again, use a medium. The Ames medium is a very good GI, intestinal transport medium. And it really should be in cool environment, but not frozen. And if you are going to use it for ELISA testing, it really should not be placed in a medium, like a transport medium. And I remember going through all this, I didn't remember all these guidelines, and most people just, have a turd and pop it in and just go out, thinking it's going to give you the answer. And if you don't do it right, it's not cheap to do this test. And I just think that we really should owe it to the clients to try to do the best you can in the sample collection. So the main organisms of interest is the Clostridial family, the difficile and perfringens, Salmonella, Campylobacter, and E.Coli. Okay, and I'll go ahead and probably start it out. Actually, I'll just go with the E.Coli because this is actually kind of cool because I don't know what year everyone graduated, but I think this is somewhat new in the past 7 years. But I remember it became really trendy during the end of my residency. And what it was is, E. coli, we know it's a gram-negative, non-sporing rod, and it's part of the normal flora. So that's pretty much most of what poop is made out of. And, but there are some virulent factors that impair local and systemic immunity in some of these E. coli organisms. And the main pathogenic strains are the enteropathogenic E. coli, the EPEC, the enterotoxigenic E. coli, ETEC, and then there's a NTC, the necrotoxigenic, and enteroinvasive E. coli, and enteroaggregative E. coli. And then the newer one is adherent invasive E. coli. That's kind of more important in our veterinary medicine literature, and I'll kind of go more specifically. And that's histiocytic ulcerative granulomatous colitis. And historically, I remember as a vet student, we were taught to immune suppress these guys. And it was thought to be idiopathic immune-mediated disease. And the histopath should be a PAS positive macrophages in the colon, so it's histiocytic, you know. And those are macrophages in a tissue level. And now we found that it's actually an E. coli bug, which is the adherent and invasive form that actually attaches to the colonic mucosa and macrophages. And it seems like the boxer is predisposed. So, and it was interesting because in my residency, I had a boxer colitis case, and we were about to immune suppress, and dog wasn't doing very well. And I did my training at Ohio State, and Dr. Sue Johnson said, you know, there's a GI Bible that we use. It's the Gastroenterology by Guilford. And she talked to him, and there was something about like this old, you know, antibiotic, you know, using Baytril for some cases, but there's no publications, no papers or anything like that. It's kind of like just word of mouth. And so she talked to me and I said, let's try, and it really worked. And it was really, really amazing. And we were so excited because, you know, this dog had the classic, you know, PAS positive macrophages, and the dog was not on steroids. We're like, ooh, this is really cool. Is it just kind of fluke thing? And then we had another case that had similar thing. We tried it again and it worked again. And these are really, you know, difficult cases because they're usually having accidents because it's colon, so there's a lot of urgency, there's hemorrhagic, so nobody really wants to be living with a dog like that. So they're usually, you got to get a solution very quick. And then with the steroids, there's all this negative side effects. So we just got really excited. And then my resident mate also did a case, and it was like a third case. Eventually, I had a collection of these cases, and he put it all together and did a paper, and that's where we started going, hey, we should throw it out there. And it was presented at one of the ACVIMs, and then everyone's kind of doing it. And then, but at that time, we still didn't know what it was. We knew it was responsive to Baytril or Enrofloxacin, and that's pretty much it. But we never were able to identify the organism. And but then eventually, it came out in future papers that they actually were able to. So it was pretty neat. So the main thing is severe large bowel diarrhea with marked weight loss and inappetence, and they're typically boxers, but I have to throw out there that I definitely have treated at least 3 other breeds. You know, one of them was mixed, one was like a white shepherd, so it's not only in boxers, but obviously you know, it's called boxer colitis for a reason because majority of them were boxers. And they noted that sometimes French bulldogs and border collie had this. And you'll often get to a point where it's so severe that you will have low albumin and microcytic anemia. So again, it's pathognomonic really for mucosal infiltration of PAS positive macrophages, and there's ulceration and loss of goblet cells. And there's not many things that are pathognomonic when you're talking about biopsies in the GI, and this is one. And really, ideally, should be culturing and biopsying to really maximize the therapy. And we never did that before, but now there's reason because we are seeing more resistance. Unfortunately, some of these guys are not responding to enrofloxacin anymore. So the standard treatment is enrofloxacin, but really other fluoroquinolones are possible. And because we're seeing more enrofloxacin resistance, but maybe we have to start considering marbofloxacin. I'm still not a huge fan of ciprofloxacin, the one that I know a lot of clients will kind of really want because it's cheaper, human pharmacies will prescribe it, but the absorption, bioavailability in animals is still not as good compared to like Xenoquin or Baytril and such, so just be aware of that. And sometimes it will work, but again, if I have a really critical case, I'm probably going to be using the vet-labeled stuff more because pharmacokinetic studies seems to have a little bit more bioavailability. And the standard dose is 10 mg per kg, and I can't find the paper that I read, and because it was a whole thing about fluoroquinolones and the pharmacokinetics in animals and absorption. Do you have any of the Pfizer people remember, or do you know anything about that paper? I don't know. Okay, it was in a paper. It was one of those things that, you know, you're trying to clean up your shelf, and you're like, oh, and you look at it, you have them like dust off the thing, and then you start looking at it. It was really interesting because it was looking at the dose ranges, and we used to, you know, the standard dose of Baytril, most people would use like 5 mg per kg once a day. But pharmacokinetically, that's not really strong enough for a lot of these treatments. So now I always dose at least 7 mg per kg, but you can go to 7 to 15, you know, so it's a lot of time it's a higher range than what we used to use. And so the consensus report, you know, recommend 10 mg per kg once a day, but it's for 8 weeks. And as we know, you know, the veterinary label product is really expensive. And that's where I know it's very difficult to get owners to be committed, because a lot of times the resolution will occur in about 2 weeks' time, you know, and sometimes even sooner, you know, about 7 days. But you really have to go through the whole course, because what happens, just like any kind of urinary tract infection as pyelonephritis, these are deep tissue infections in the macrophages. If you just resolve by clinical signs, it's still in there, and now you're going to shoot yourself in the foot because it's going to be resistant. And that's what we're seeing now. And I have a feeling, because it got all excited, everyone's trying to use it, but most people will probably just do it for 2 weeks or so, because no one's going to convince the owner to say, all right, it's going to be like $300, $400 for this, you know, 2-3 weeks, depending on the dog size. But it's really important to stress to the owner that if you don't want resistance, you really have to complete a full, at least 8 weeks. And now we're seeing in fluoroquinolone, about 43% could be resistant. So it's a little bit unfortunate, you know. Maybe we just got too overzealous, because we never culture. We just started treating it because we were so excited that, oh, we have the answer. But I think with anything with antibiotics and the proper treatment, we're seeing a lot more resistance, and MRSAs and UTI-resistant cases. So if there is lack of clinical response, it's probably potentially related to maybe drug distribution as a possibility, but maybe there's still other factors that are making it very difficult for the animal to clear it. You know, maybe there's a genetic predisposition. How did they get in the first place? You know, such thoughts are definitely out there. So this is just a paper that talks about the resistance. We're seeing more and more of them. So it's getting more common in this 2010 JVIM article, and that just noted that antimicrobial resistance is common in granulomatous colitis in boxers, or really just the E.Coli type. And really, they highly recommend that we actually culture the mucosa and go from there, you know. And I think that it's still very difficult, because right now, when you have a dog with really bloody diarrhea, owner wants to answer really quickly. I think it's hard to sell on the owner, because if you really want to diagnose it properly, because there still could be other differentials, histoplasmosis, inflammatory bowel disease, GI cancer, especially when you talk about so much blood that's coming out sometimes, you know, there can be masses. And I just think that you have to be careful before you commit to 8 weeks of treatment, the dog's not getting better, and you may actually be contributing to resistance. Ideally, colonoscopy would still be the gold standard before you just empirically treat. But I realize that it's not always easy to, you know, follow through with that recommendation depending on the owner and the cost. So now I'm going to go ahead and talk about Clostridial diseases with difficile. And it's a gram-positive organism. It's anaerobic spore forming. And it is in forms of a vegetative cell, or it could be in spores. Okay? And really, the vegetative cells are the ones that are responsible for disease, as they make toxins and such. It's frequently seen in human-associated infections. But really what's interesting, the reason why we're going to throw it out there is that it is even a big player in our diarrhea dogs. And 10 to 21% of cases of diarrhea in dogs, but it can be found in 0 to 58% of normal, healthy dogs, non-diarrhea. And I think this really hits home of what is considered normal and what's considered abnormal when you start to require treatment. But I do have to say that a lot of your HGEs, acute hemorrhagic diarrhea syndrome, probably there's a strong association, but we cannot do causation, you know. And shedding appears to be very variable and transient in a sense that, you know, maybe it's just more indicative of frequent exposure from food, environment, or short-term colonization. really little information is known about cats, when you look at the feces. And in colonization rates in cats, it seems in general populations is 0 to 21%. So it is less than dogs, and only 9 to 38%, however, in vet hospitals when they look at some of the studies. So risk factors, really immune compromise, antibiotic administration, and contact with children and visiting human hospitals. Those are definitely possible risk factors when you kind of look at these big studies and trying to retrospectively look what were some common denominators. But really, the clinical significance is really questionable because many of them can be subclinical, but then eventually if you have that horrible HGE, it could be fatal. And I think it's important to note that there is no specific anatomic localization. A lot of people think of Clostridial disease as like colon, large bowel, but it can be small or mixed, as in small and large. So how do you diagnose it? And this is where it's tricky because cats and dogs really have a high baseline colonization. You take an average animal that's healthy, they can have Clostridial difficile even. And that's where maybe real-time PCR, antigen, ELISA, and culture may be helpful. But the problem is that when you do the antigen, ELISA, and culture, you cannot differentiate between the toxigenic strains and the non-toxigenic strains. So that's where we got really excited about the toxins that you're actually looking for. So there are two main toxins, A and B. And the gold standard is really a cell culture of cytotoxicity, but it's definitely not practical. You're not going to find any lab that's going to do that for you, really, unless it's at university or something. So commercially, there's a ELISA, but the problem is that it's very moderate to poor sensitivity and specificity in dogs. So that's where we thought, well, maybe we need to look at for the organism and look for the toxin. So the combination of both is probably the best thing that we can do to truly say, all right, this dog may have Clostridial difficile and that's causing disease, but it's still not perfect. And usually you would use the ELISA for the toxin A and B, and you would actually culture or use the antigen ELISA or real-time PCR. But if you have a toxin A negative and a toxin B positive strains, it seems to be that's the majority of many of the dogs. And presumptive diagnosis is positive for toxin and organism. So you kind of have to have both for a presumptive diagnosis. But if you only detect the toxin with no organism, it's really have to interpret with caution because there's actually really quite high sensitivity in the organism detection compared to the toxin. So if you can't even find the organism, that's probably that's the most sensitive test, then it makes you question about maybe that there's that kind of false positive for the toxin. Because again, it's not the greatest toxin test that we have out there, but we don't have anything better. And if you only have a possible infection, if it's positive for organism but negative for toxin. So how do you go ahead and manage these cases if you think there is a Clostridial issue? And with difficile, really it's just supportive. And if it's triggered because there are antibiotics, kind of when you're talking about the some sources of antibiotics that may cause diarrhea, obviously stopping the antibiotic therapy can be helpful. And if you ever have to use parental antimicrobials, it's probably pretty rare, okay, if it's for difficile. But obviously, when you have that really sick HGE dog that looks like in septic shock and all that, you're using it not to get the Clostridial organism, you're just trying to protect it because the mucosa barrier is really, really vulnerable. So metronidazole typically is pretty effective for Clostridial difficile, and usually for 5 days. And in people, they actually would use vancomycin, but we don't recommend doing that in animals because we're really seeing a lot of resistance in humans. So we don't want to kind of add to that. And if you want to use intestinal absorbents or diet, probiotics, fiber, that's fine, But really, is it really getting that organism? You're really just treating symptomatically for the diarrhea. Yeah. Well, it's one of those things that probiotics, the last talk that I went to for the ACVIM last year, there's just a lot of question about probiotics, about more the quality of what's being out there pushed to the owners. So I don't usually use probiotics. I'm going to use metronidazole. I find that that's going to be more effective. And then I feel like if you are going to use metronidazole, you are going to kill some of the organism, from probiotics. And until we truly know the standard of what is the quantity of a probiotic that's needed to help that animal, we just don't know. And I know that's a big thing with human medicine on top of veterinary medicine. And now there's like so many things on the market that's totally not FDA approved. It's not really regulated. And then they're talking about there's only some of them that's really for GI bacteria for dogs. I think there's only one brand. I don't remember the name of it, but it's supposed to be, that's the only brand that actually was made for the normal flora, that helps the flora for the dog, because everything else is extrapolated from humans, which our gut is not the same as a dog's gut. So I think if you feel like it works, I'm not going to say don't use it, but I personally don't use probiotics. But metronidazole seems to be quite effective, I find. So the potential for zoonotics is really unclear, and it's really indistinguishable from the human pathogen strain. Okay. So then we have the other cluster. Did anyone on difficile? Any questions? I mean, pretty much the key point is that a lot of normal dogs have it, and how are you going to go about differentiating? In all practicality, I think it'd be very rare for me to just try to sit there and culture and run a toxin A and B, unless you have that really sick animal that you really the owner wants to do everything possible, I would. But I think the average owner, it's not cheap tests to run, and you're going to be treating supportively, no matter what. And definitely be having a dog on metronidazole. I think that's pretty common for probably most of us. But I do think it's important for you to know the background, so therefore it's not just kind of empirical treatment, so you kind of know why or what, and what the true gold standard is. So Clostridium perfringens, another same question. It's like, is this a pathogen in dogs or cats? And it's really a part of the normal flora. It's cultured more frequently in diuretic dogs and non-diuretic dogs, 80%, but it seems to be lower again in cats. And with the diarrhea-associated Clostridium perfringens, you're talking about the different enterotoxin. It's called the CPE, Clostridial enterotoxin, CPE. But again, up to 34% of diarrheic dogs have this, and then 5 to 14 of non-diarrheic dogs. And I hate that overlap. That's what's so frustrating. And how do you make it, make sense to, is this what's really causing the animal's problems? But in cats, it definitely seems a lot less. Only 2% of non-diuretic cats had it, and 4% had it in a study that looked at 219, and then it was nine cats that were diuretic with it. So is this toxin associated with HGE? 67% of HGE dogs had it, 8 of 12 in one study. And they think maybe there's a disruption of microenvironment enabling sporulation of the commensal enterotoxic C. perfringens that is making this disease kind of activated. So how do you diagnose it? Another no gold standard. And a lot of times people will use ELISA CPE in conjunction with PCR. So you're looking for enterotoxic strains, and you're also looking for the actual toxin. And if you just culture this alone, it's not sufficient to diagnose it. And that's where I feel like when the whole thing about culturing feces and such, I think it's just really tricky, because so many animals will have various pathogenic, what we think pathogenic organisms, but it just happen to be also in healthy dogs. And the fecal endospore count, and we kind of talked about this one during the break, it's just like, what do you make of these fecal endospores? And it really is difficult, because sporulation is correlated with enterotoxin production, but there's no association between counts and the presence of diarrhea or detection of this toxin, the CPE toxin, because as it occurs in normal dogs. And I know back in school, they taught us maybe 3 to 5, greater than 3 to 5. And I forgot, Dr. Mentz, what were you taught in your school? You said something about a certain number. What was your count? I think everybody varies.
Oh, you mean percent sporulated?
Yeah, like how many sporulation per high powered field? Do you remember?
30 to 25%.
Yeah, so you know, like I think every vet school, everybody has like a different number. Maybe you're taught to look for the certain count that has a threshold, and if it goes beyond that, maybe that's where it's significant. But again, at least some of the papers are saying that there are some dogs that actually sporulate quite a bit, and there's no diarrhea. But at the same time, you see a lot. I think it has to be on your radar, though. Again, there's no pathognomonic signs, and it can be small, large, or mixed. And really similar to the other one, just it's pretty much HGE, can mild to moderate, which we know, you know. But, you know, looking at the actual enterotoxin, you can try to use this reverse passive-related agglutination assay, but it's not as practical sending out compared to ELISA. But the problem with the ELISA, there's a lot of problems with maybe sensitivity and specificity. And in this case, sensitivity is even more important because it seems like it has to do with the concentration of the CPE toxin that's related to disease. And again, 14% of healthy dogs can have CPE, you know, positive in ELISA, but maybe the quantity is more important. So the diagnosis is CPE by ELISA with PCR detection of enterotoxigenic strains. What the PCR is trying to amplify is the segment that makes the toxin, and there's several targets on that gene. One's a CPE gene, which is pretty much the one that makes the CPE toxin. There's a CBP2 and an alpha toxin. But alpha toxin seems like there's a lot of questions about true virulence, so really the CPE and the CBP2 PCRs are the ones that may be helpful to tell you, yes, there's that strain, it makes, and then you have to look for the toxin. As non-diuretic dogs are less likely to be both positive for both. That's why you did this type of comparison. So treatment of Clostridial perfringens, it's again needed for systemically ill, hemorrhagic gastroenteritis, inflammatory or toxic leukogram. Really, those are the ones that are classically sick, like our HGE dogs. And this one, actually, you can use ampicillin, erythromycin, metronidazole, tylosin, tetracycline. And there's a high rate of resistance in vitro in some of these some of these antibiotics. So sometimes you have to make sure that even it looks great in the lab, but if the dog's not responding, you might have to switch antibiotics. And that's where I think most people still grab metronidazole because you're going to get a lot more stuff, you know. And which kind of, I'm going to go back a little bit. And I don't know if you guys remember what do they call it? SIBO, you know, small intestinal bacterial overgrowth. Now they're terming it, now they change names because they don't feel like that's proper because there's been studies that what is true overgrowth in the small intestine. We really don't know that number, and again, healthy animals can have super high counts. But then, however, we know that sometimes they respond to antibiotics, and the ones that typically respond, if I have a small bowel diarrhea, I want to try antibiotic responsive diarrhea treatment, I would use tylosin, or oftentimes I'll use doxycycline. But if it works, you could try to use tylosin. They're almost interchangeable. And I wonder, is it because there's Clostridial? I don't know. It seems to change the floor a little bit for small intestinal overgrowth. We call it small intestinal overgrowth, but now we call it antibiotic responsive diarrhea. It's more proper terminology because we really don't know what that overgrowth number is. Because we used to, whenever we did our scoping, we used to kind of collect fluid. You give a wash, then you collect the fluid, about a mil or two, and then you culture it. And they actually had the micro lab sit there and do a colony count to see how many were there in the duodenum, and that's how we diagnose SIBO, you know. But then there's like numbers were all over the place. You know, what happens if you didn't do a good wash, and you know, there's so many variables that people just kind of tossed it out. And so now a lot of people will just try tylosin or doxycycline first. Anybody have questions on Clostridial perfringens or anything? So Salmonella, gram-negative, motile, and non-spore-forming, facultative anaerobe bacilli. And they're all they're pathogens in dogs and cats, but often subclinical. Not all strains are equally capable of causing disease, and there is probably an infectious dose. Multiple factors in host and organism, and the prevalence in healthy dogs and cats are similar to the diarrheic cats. And you'll see that theme over and over again. Healthy animals have pathogenic strains that we consider pathogenic, but they're okay. I think that's why they can lick their butt and not be sick. I always wonder, like, why are we different, you know? And I feel like there has to be a link, because I think that's not normal. I mean, dogs eat like cat poop and they're happy, you know, and they don't get sick the majority of the time. So I just feel that there's something there. So prevalence of Salmonella. Healthy dogs, 0 to 3.6. Diarrheic dogs, 0 to 3.5, and cats 0 to 8.6. So definitely less compared to Clostridial cases. And stray dogs seem to be a little bit higher. And it probably has to do sometimes with the raw foods. You know, like when you're really into the raw food diet, you know, you could get it from raw chicken, but you could really get it from any kind of raw meats. It's everywhere. And when they found these dogs that ate the raw meat diets, you know, 80% of them had the Salmonella. Again, they don't have to be sick necessarily. And then they also were isolating from greyhounds eating raw diets, about 30%. And Alaskan sled dogs, and they typically eat raw meats, and 60 to 70%. These are very healthy dogs, you know. But I do feel that because it's a pathogen for humans, and you know, a lot of fecal-oral contamination, I'm still not a big proponent of this, the raw diet, quite honestly. I don't know what everyone's personal opinion is, but if I have an owner that really wants to do it, but he's a chemo patient, immune compromised, I just don't think it's worth taking that chance, because some animals will get sick. But again, this makes it very difficult to diagnose, because isolation alone does not, you know, diagnose Salmonella-induced enteritis. So signs, mostly if you are going to get sick from it, it's pretty acute disease, and it's highly variable again. It's usually 3 to 5 days after exposure, but it can be even after as soon as 12 hours later. It really just depends on the ingestion load. So you can have fever, malaise, anorexia, followed by vomiting, abdominal pain, diarrhea. And then a lot of times it could, you know, various types of, you know, large bowel, small bowel, you know, issues. So how do you diagnose it? Again, culture. But the key point with this culture, though, is that you have to culture multiple times, because it has a really low sensitivity. And you really have to do at least 3 consecutive negative cultures are needed to be 90% confident that it is a true negative. And that's one thing that I think a lot of people don't realize when you're culturing that feces. Again, it's not just one sample. It depends on what you're trying to target. So if you're really interested in Salmonella, very acute disease, dogs on raw diet, whatever, you know, or the owner's kind of immune compromised, you really want to make sure you don't have something like a horrible, you know, Salmonella case, then really should be taking multiple samples. But if you want to be 99% confident, you have to do 6 collections. So PCR, there's no multi-center validation, so every lab kind of does their own thing, kind of. But recommend PCR after overnight enrichment in non-selected broth. So this is the pain in the butt factor, where I feel like some of these testings is just not as practical in the real world. And but the main thing, you're supposed to do non-selective broth media, and that's a gold standard. And then once you culture it, then they'll see, all right, this one is positive in the PCR result. So then you'll take that sample, and then that's the sample that you're going to use selective enrichment to isolate and identify the organism. But hopefully the lab will kind of do all this, where you just give the poop. Management of Salmonella, administration of antimicrobial, this is really not warranted in uncomplicated episodes. And again, if you're a systemic disease or there's immune compromised patient, you know, ampicillin and Batril, you know, Enrofloxacin is an advocate, but really any of the fluoroquinolones. And ideally should be based on cultural sensitivity, but I realize that it's not always easy to do that. Treatment of animals is not advocated if owner is immune compromised, rather enforce appropriate husbandry. Okay. Campylobacter, it's the gram-negative microaerophilic curved motile rods, and most are non-pathogenic. And again, isolation rates are very similar with the healthy animals to diarrheic animals. But this is one that's usually young dogs, okay? So dogs that are diuretic less than 12 months, they were able to find jejuni, Upsilinus, and also it had 2 times the prevalence rate compared to non-diuretic cases. But you didn't see this association was greater than 1 year of age, so it is a young dog disease. And you could use quantitative PCR in dog feces found in the diarrhea, but they had more Campylobacter and increased diversity of species compared to non-diuretic dogs. So there's many different types of species. So typically, again, young animals, puppies are mild clinical disease, and kittens really didn't show any signs when they tried to inoculate kittens with it. So it seems like more of a dog issue. So again, the prevalence is highly variable in dog and cat, and maybe crowded conditions, young dogs less than a year, cats less than 36 months, home-cooked diets with table food scraps in dogs, and a sampling in winter months versus spring and summer. It seems like that even affected who seemed to have it. So that's probably where how you sample it, and maybe, I don't know if there's a, I don't know what the link exactly is, maybe more of the feces, how it's collected, I'm not really sure. Because it's a pretty sensitive organism that can die. And then cats that have access to outdoors tend to be a higher isolation. And I suspect it's probably more hunting, eating raw foods and such, most likely. And maybe if you have a dog, well, I guess it probably makes more sense with cats if you're hunting more in the spring and summer than winter. But the main one is Campylobacter Upsilinus that is most frequent in dog feces. And Helveticus is also commonly isolated in cats. So many cases of healthy animals are only carriers, and puppies less than 6 months, or those who are from stressful environments, they may have these kind of mild loose stool, bloody mucodiarrhea, and just acute onset of disease. And this is the part where an identification on gram stain, if you do it, everyone in school learns about the gull wing, and it's kind of just like a little squiggly line. And the key thing is that all you can say is Campyl-like organisms, because in feces you do have the Archobacter, and there's also just tons of non-pathogenic strains, which most of them are non-pathogenic. So I think that's just really tricky, again, looking at feces and the smear to say, all right, you see wing goal-shaped, is this going to be significant? I think you have a young dog that's like less than 6 months, having clinical signs, maybe it would be truly more significant, but I think that if you find it in, randomly, or even you're looking for it, just be careful about over-interpretation. And then that's where they actually do different biochemical testing and thermal tolerance. They're hoping that they could differentiate between species, but it really is variable. And really the best thing is probably the PCR direct sequencing to help differentiate between species, because a lot of them are actually non-pathogenic. So the good news is at least most are uncomplicated, self-limiting, and resolves with supportive care. And you really want to treat the immune compromised in the febrile, and again, the kind of like the HGE kind of dogs. And the macrolides or fluoroquinolones are the treatment of choice, but in people we're seeing more and more resistance to the fluoroquinolones. So those are the dosing for the erythromycin or azithromycin, and usually the length of time. But we really don't know how long you kind of have to treat for. But most dogs and cats, they do quite well. And oftentimes when it's failure, it's probably maybe resistance, but a lot of times it could just be the wrong diagnosis. So zoonosis of Campylobacter, it does cause diarrhea in people. So, just be aware of that. But really, it's interesting to see that the humans, there are some immune diseases that come after a Campylobacter infection. And I find that just interesting because I still feel like dogs, just have a lot of autoimmune disease, I feel, compared to like cats in people. And get this, I'm just kind of thinking out loud, so I probably should just keep quiet. But the main thing is that, like, why? And I wonder, is it because they eat feces or they do, random stuff? Again, it's all about the feces. What are they eating? And then because if you eat, people with Campylobacter, they trigger some immune response. I just think, on average in our hospital, we'll probably have like 2 IMHAs in the hospital in a week, easily, and I just think that's just way too many, compared to any other autoimmune diseases and such. In cats or humans. So relationship with C. jejuni, enteric disease in humans, especially young immune compromised, but again in cats it's going to be young animals. And oftentimes they're in the same household. So after all this, it's really like, how do we go about controlling enteropathogenic bacteria? It's really just common sense, proper cleaning, disinfection, hand washing. But I did find it very interesting to note that the alcohol-based hand sanitizers won't kill a lot of these organisms. It will not do the clostridiols. So you just have to be careful now, and where you truly have to, if you have a diuretic dog and you got a little messy, it's truly a good old hand washing with soap and water versus the squirts on your hand. And this is something that we probably should do in our hospital, because it's like we walk animals in the same little patch because it's a fenced-in area, but really, if you have a diuretic animal, it's really ideally should be promptly removed, and we do our best to do that. But I know it's just always difficult in your environment where all the dogs get walked, and it's easy to kind of contaminate each other. And Clostridial spores, highly resistant to most disinfectants, but susceptible to bleach. So you do 1 to 10 to 1 to 20 for the spore, killing of the spores.